Hello, everyone, and welcome back to another session of Oral Pathology Tuesdays right here on Oral Pathology 360. I'm Dr. Mandana Donahue, your host for these events and the founder, director of Oral Pathology 360, your home for everything you need to learn in the diagnosis and management of oral and maxillofacial diseases on the web. Before we start, a quick reminder our YouTube membership it offers fantastic perks, including participation certificates just for attending these live streams and participating. And you can check out the details and join by clicking the join button below the video. And on that note, let's thank and warmly welcome our newest member, Dr. Maza. We are delighted that you have joined our community. And moving on from there, we have an exciting event. We have a giveaway again. We had one last time and it was quite fun. Let's see how this one works out. So, what's the giveaway? It's a free registration for the upcoming Virtual International Oral Diseases Case Presentation Conference 2025 that is happening between May 2nd to 4th. It's a truly multidisciplinary conference and it promises enriching lectures, interactive case presentations, pre conference tracks, CDE credits, 15 days replay access, literally and absolutely anything that you want. It's there. So, to enter the giveaway, which is your chance to get a free entry, you will need to type hashtag IODCPC25 in the live chat and make sure you stay till the end where we will have the draw, but also so that you can find out more about a prestigious award we have instituted for institutions. It is the Excellence in Learning and Leadership Award. So we'll talk about the award and also tell you which institution is currently leading right at the end. So you got to stay till the end. Okay, now turning to today's session. A teacher affects eternity. She can never tell where her influence stops. Our speaker today truly embodies these words. Dr. Sharadha P, passionate educator, dedicated mentor, and a pillar of excellence in oral pathology, whose legacy continues to inspire generations and who is very well known and very dear to most of us in the Indian fraternity, is here with us, and it's an absolute honor to have her. She is going to be talking to us about something very fundamental, grossing in oral pathology, the art and science of specimen examination. So let me bring her in. Okay, I forgot to add myself. Right. So, welcome, ma'am. It is wonderful to have you with us, and we are really looking forward to the lecture. But before we start, I would really love for you to tell us a little bit about what you are currently doing.
Good evening, Dr. Mandana. Thank you for the kind words and introduction. I'm really honored. And I am Dr. Sharda. I completed my BDS from Nara Hospital Dental College way back in 1984 and my post graduation from Nara Hospital Dental College in 1987. I have about 34 years of teaching experience. I worked as a to the capacity of professor and HOD in BS Dental College for 16 years and AECS Maruti Dental College for another 16 years. So I have 34 years of teaching experience and I've taught postgraduates for about 15 years and undergraduates for about 34 years. And presently, I'm a practicing oral pathologist tied up with Oral D and Dr. Badranna's oral histopathology services. And I'm blessed to be here today. Thank you for giving me an opportunity, Dr. Mandana.
Thank you so much, ma'am. It is really our good luck that you are here with us. So, I'm not going to take more of your time. It is time for your lecture. I think everyone is waiting. So, I'll move to the lecture and you can just start.
Good evening, a very good evening to all those who are present here today. And It's my pleasure to present a very interesting topic in oral and maxillofacial pathology, that is, grossing in oral pathology, the art and science of specimen examination. So, what actually is grossing? In surgical pathology, microscopic examination is grossing. It is derived from the Latin word grossus, which means rough. That means what we see with the naked eye. The synonymous or the meaning of it is sampling, and British terminology, it means cut in or dissection, histology dissection. So, why do we actually want to do crossing? Let us see this prime model. P. P of prime stands for picture. So, why is what we need to see when we get the specimen is why was the procedure actually performed and what is the overall picture? And we need to take pictures, draw a picture, take a radiograph, and if we are cutting through the section, we need to see what axis was it cut. So, and a picture is very important at this stage. Next, the R, that is relationship. What it means is what are the structures present? What is the relation of this lesion with the surrounding structures and the margins? So, what is I? I is description of the tissue and cut section. Like for many biopsies, the cut section gives us a lot of clues for the diagnosis. Like if it's cystic, if there's any cystic content, gelatin like material, or there is necrosis, or there are calcifications, that all are very important clues for a diagnosis. Margins. M stands for margins. Like when the surgeon has sent us a specimen, if it's a hemimandibulectomy or maxillectomy or hemiglossectomy, were the margins stapled or clipped or were they inked? Last is E, external, which means what are the dimensions, the description of external surface of the specimen. Are there any lymph nodes which are palpable? So all these give a clue to the diagnosis and help us in the grossing process. So, this is a prime model for grossing. Now, the College of American Pathologists has given us a protocol which is a standardized approach to grossing, staging, and reporting of specimens from patients with cancers of oral cavity. So, let us begin with the basics first. What is a gross room? All the specimens that we get, we collect it in the gross room. It is a bridge between the surgeon and diagnostic surgical pathologist. It should be large, ventilated with exhaust fan to do away with the formalin fumes. And we should also have, other than having formalin, large table for dissection, X-ray unit with view box is very important. Photographic facility is very important. Refrigerator is important to store the specimens. The grossing station. The grossing station was introduced way back in 1980s. We have three types of grossing stations: the standard grossing station, the heavy duty grossing station, and the island type. So this grossing station, the first one, this one is a heavy duty grossing station where we gross bone specimens and bulky specimens. And this is a standard grossing station which some of the colleges do have right now. And this is a schematic representation of the grossing station. If any of the youngsters and postgraduate students are there, they can always go through this and see what are the requirements and what the grossing station actually has. Then grossing tools. We are very much aware of the grossing tools. Main thing is we need a good grossing table, a scalpel handle with blades, tooth forceps, ruler, scissors, and pins for attaching bigger specimens to the cork surface, tissue cassettes, and labels. I'm sure you all must know about all these things. The very basic. I started with the basic first. Now, to begin with, the requisition form. What do we do? The first thing when we get a sample in the gross room, or when the surgical pathologist, surgeon sends us a specimen, what we have to first see is the details on the bottle and the details on the requisition form are the same, like the patient's name, age, sex, type of biopsy, number of biopsy tissues, and any clinical and radiographic details and any other investigations done. So we need to match the specimen label with the requisition form. Now we, from Dr. Badrina's oral pathology, we have shared the Google form where there is where the surgeon can even upload the clinical pictures, radiographic pictures, and any investigations done. This is a requisition form from the American University of Chicago. I'll just put it as for your reference. The second step, now we have received the specimen, we have checked the name on the sample, the details on the sample bottle, and also on the requisition form. We have found it to be correct. Now we have to see if the specimen was sent in 10% formalin. And the ratio of this formalin, 15 to 20 ml, is to 1. That is fixative to tissue specimen. Now, why do we want to uh, fix the specimen? We want to keep the cells in a life-like state and also harden the specimen. If the specimen is soft and we try to cut it at that stage, it's going to mutilate the specimen. So we need to harden the specimen. Now, when do we know the end point of fixation? If there is any blood clot and it takes up a tan brown due to acid hematine, that is the end point of fixation. Now, sometimes the surgeon may not be having formalin in the clinic or in the hospital. A situation like that, it is better to use, they can use formalin tissue safe for short term storage, which has been developed by Milestone Medical Italy. This uses a combination of vacuum storage, which is vacuum bag and refrigeration. Specimen can be stored for 72 hours. If the formalin is present and the specimen is in formalin, but the surgeon is not in a position to send it the same day, they can refrigerate at 4 degrees centigrade. In case they want to send it the next day and the formalin is not with them, they can preserve in isotonic sodium chloride, which prevents drying of specimen. But the problem with this is ancillary studies may not be possible because it alters the cellular morphology. Now, if we get cystic cavity or a cyst and it is showing some contents, what we need to do is we need to remove all those cystic contents and inject formalin with a syringe or pat gauze or cotton impregnated with formalin into the cystic cavity. The third step, now we have seen and we have observed that the tissue is well placed in formalin. Now we have to assign a number from our lab for each patient. So if we are taking 2 to 3 specimens from from the same specimen, we need to give 1A, 1B, and so on. If this from multiple specimens of the same patient. Now, these days, barcoding is used. It reduces the laboratory errors and it increases the efficiency. Now, each barcode is connected at every step, right from accessioning to grossing to tissue processing to embedding, micro sectioning, and staining, and then again to the pathologist's uh, workstation. Now there are two types of barcodes. Linear 1D barcodes which have vertical lines. This picture on the right. They have vertical lines and spaces between them which enclose data, and it is read from left to right. Whereas this one, which is a matrix 2D barcode dot matrix, it has many uh, dots, squares, and uh, it can be read vertically and horizontally. The advantage of this is it can store text and images. Then we have these RFID tags. There are two types. The active RFID tags are useful. They use battery power tags, and we can scan the specimen at every checkpoint. Checkpoint means accessioning, grossing, then processing, embedding, sectioning, staining, and then to the pathologist's workstation. The passive RFID tags they help us to securely and efficiently manage the specimens. Now, handling of specimens is the next step. Use of surgical instruments which are heated because it will cause artifacts in the section, and use of sharp surgical instruments to be avoided. Now, the next step in this is describe the specimen. We place a specimen on the cutting board in an anatomical position as it is seen in the oral cavity. Then we need to see, record what specimen is it? Is it soft tissue, hard tissue? It is a cystic lesion, it is a bone. We have to record the type of specimen. Then the type of biopsy, whether it is incisional, excisional, core biopsy, or is it hemimandibulectomy or hemimaxillectomy or hemiglossectomy and so on. And what are the structures included? We need, and what is there any nerve included? Are there any blood vessels included, which is rare? And dimensions of the specimen. We need to measure the specimen, the shape. What is the shape of the specimen? What is the color of the specimen? And how many tissues have been sent? And if there is any foreign material. Now, if it's a clearance report, that means if it is already it been diagnosed, like say for example, if it has already been diagnosed as a CA, we need to mention the extent of the lesion, lymphovascular invasion, vascular invasion, lymph node involvement, and all these. So we have to check while grossing. We have to check all these structures. We have to, gross all these structures in the specimen. If the diagnosis is already known as CA, then photography is the most important part of grossing. It should be taken prior to sampling and after sampling. Why is photography important? It is important for telepathology. If we want to share the gross pictures with somebody and take a second opinion, for permanent documentation, especially any medico legal cases or issues, and not only the gross specimen, we have to take a photograph at that stage, and also the cut surface. The cut surface will give us a lot of clues, and we need to see the cut surface may show necrosis, it may show hard tissue, it may show hemorrhage, it may show a cystic cavity. So, all these contents can be recorded, and when we take the photograph, we can store all these images. Of course, now digital imaging is happening. The principles of photography, if people are not using the digital, even for digital imaging, we need a well illuminated place. Background should be clean, and the color should be preferably light blue. It is like a grayish color intensity, light blue. Then we need to rinse blood and fluid from the surface, blot dry. Sometimes blood and any friable tissue, to prevent cross contamination, we can always wrap it in tissue paper or gauze and send it for processing, so that there's no cross contamination. If we think the blood clot or the blood content is not important, we can always rinse it. And the specimen should be properly oriented. Knife marks should be avoided because that will be reflected as an artifact in the microscopic section. The fresh specimen color is best. The fixed specimen we get the details, very good details can be seen. Now, ruler we use when we want to know the size, and the size is important. As you see in the picture, the ruler is always placed in the anatomical inferior position and at the level of the specimen, which is very clear in the picture shown. Now, crossing instruments like what you see in the picture, forceps or our hands or probes, scissors, should be avoided in the field when we take a photograph. Then radiography. Why is radiography important? We will know the size and the location of the lesion in the bone. That is the most important part. We will also know whether it is unicystic or multicystic, or whether any bone present or hard tissue present, and any radiopaque foci present. We can correlate, we can have get a correlation, radiopathologic correlation, and we can also know if the if the lesion has been removed completely, and also microradiography. What is this microradiography? It tells us about the uh, mineral content and density and the structure of bone. So radiographs are important. And now, after we have received the specimen, we have seen that it is in formalin, and we have checked the number, the labeling, we have crossed the tissue, and we have to do the sampling. So the sampling comes in various steps. First is only gross. We don't process some tissues. So gross only, it is a dictation and report describing the physical appearance of the specimen. Like you can see in the picture, like screws, pins, plates, like screws and rods and all, you will find if the patient has had a fracture and some rods and screws have been placed. So such specimens, we don't process it, we just give a report that what we see based on the physical appearance of the specimen. We don't process the tissue. The other specimens that normally gross are the bony ossicles, ear cartilage, fat, then tendon, scar tissue, nasal septa. All these are only gross. Next is, so if we, that was gross only, we found some foreign body or we found some bullets and all, we have given the report. What if we get a small biopsy specimen? A small specimen is always wrapped in tissue or filter paper or gauze. And specimen should not be cut when fresh because it's going to totally mutilate the tissue, and it will also cause problems in embedding. If the specimen is less than zero point 0.2 centimeters, it's very difficult to cut. As I told you earlier, blood clot can be washed off, or we can wrap it, blood clot and friable tissues, we can wrap it in paper and process it to avoid cross contamination. Now, this is a pic showing where the smallest tissues, very small tissues, are wrapped in paper. Now, how do you complete the biopsy of a small tissue? If you receive lots of small tissues, you need to document all the fragments. And the exact dimension of every fragment should be specified, that is what is there. But at least the largest bit, we can always give the dimensions. And many fragments are made visible to the embedding person. Sometimes what happens is these small specimens will be lost, may be lost during processing. So they are made visible to the embedding person by marking with hematoxylin or a combination of eosin Y and floxin B. Sometimes we do a procedure called as dye crystallization, applying layers of hematoxylin where the tissue fragment is incorporated in the dye, but it will be lost after the first few sections when we section the specimen. So this is a picture showing the dye crystallization. You can see here hematoxylin has been used, and small specimens processed in cassettes. They should be kept in a mesh or a lens paper or a tea bag, very small specimens. And whenever we give a histopathology report, we also describe the gross. So when we are describing the gross, especially for small biopsies, we need to write entirely submitted in the report, which is a fundamental rule. It is it is mandatory to write entirely submitted, especially for small specimens. Next is a punch biopsy. We use a punch in some situations, especially buccal mucosa lesions and so on. So when we get a punch biopsy specimen, this is an instrument. Say we need to measure the depth from the surface to the depth of the punch biopsy. So this is the procedure what I've showed you how a punch biopsy is taken. This picture shows you that. But when we get the specimen, we need to measure from the surface to the depth of excision. So if it's like a tube, from the one end of the tube to the last end of the tube, we need to measure. If it is less than 3 millimeters in diameter, we need to submit as it is. But if it is between 4 to 6 millimeters in diameter, we can bisect it and place the cut surface down when we embed the tissue. So when I show you the core biopsy, you will get an idea. Now we know core biopsies mainly we use for salivary glands and we get adequate amount of tissue, but there is always a problem of tumor seeding and nerve damage, especially parotid gland, the facial nerve can get damaged. Now if it's a large core biopsy that is larger than 4 millimeters, we bisect it at two levels. That means one section will be two-third and the other section will be one-third. It's not exactly in the center. And the specimen will be embedded with the cut surface down. So why do we do that is, you can see that in the picture, this is two-third and this is one-third. And why we do that is, lesion from the center of the core is not missed. So this is a procedure we followed for a large core biopsy. If it is a small core biopsy that is less than 2 millimeters, bisecting the core will damage. It is embedded totally without cutting as you see in the picture. The punch biopsy also will appear the same. From the surface to the depth we will measure for a punch biopsy. So if it's a small core biopsy, we are not going to bisect it. We are going to totally embed it without cutting. Now it's a large excisional specimen, say a hemimaxillectomy or a hemimandibulectomy. Sometimes these large specimens tend to float on the fixative. So what we have to do is to cover it with a thick layer of gauze. If they go and sink in the bottom of the container, we need to place a gauze between the container bottom and the specimen. Next step is we orient the specimen in the anatomical position and check the surface first. Check all the surfaces of the specimen, color, texture, is it smooth surface or it's nodular, any defects, any structures attached, that is adherent structures, and what is the deviation from normal anatomy. Then the cut section will give us lot of details as I told you, cystic lesion or cystic content, what cystic contents, is it fluid or gelatin or jelly like material, or there is hemorrhage, there is calcification, there is myxoid. Now these are the various planes of sectioning. The first one, this one is a longitudinal section where we section along the longest length of the organ. Here it's an oblique section. This is a transverse section which were sectioning perpendicular to the longest length of the section. This is a transverse section again. This is for something which is not a longitudinal specimen but somewhat rounded specimen. And this is grazing specimen where we touch the surface, which is also called a tangential specimen. Now, this Morse method is usually followed for skin, but I have put it because I wanted to show the sectioning. You can do vertical or perpendicular, horizontal or parallel, and oblique. So, if it's a transverse section, we can do a bread loaf. We can also do longitudinal with bread loaf, that is bread loaf cross through the tumor and also the peripheral part of the tumor or from the edges of the specimen. So that will be bread loaf cross and transversely exactly will be bread, bread loaf. Now, transverse bread loafing always will give us a relation between the tumor and the margin. Small specimens, we usually do bread loafing. Excisional biopsy specimens about 10 millimeters or little less. First, we do a transverse section from the center of the lesion and we section the specimen at regular intervals of 2 to 3 millimeters. Now, this was what I was talking about. This was sectioned, transverse section, and then bread loafing was done. So, a combination of bread loafing and section and peripheral section. This is a periphery. So, the peripheral sectioning and bread loafing will give us a relationship between tumor to margin and also will help us to know the clearance of the margin. So, this was cut transversely and then it was bread loaf. Now, what are the types of tumor margins? So, clinical margins is what we see with our eyes in front of us once we receive the specimen. The margins of the tumor on the clinical observation and palpation. So, this is what we see. That is a clinical margin in the clinical scenario. Then we have surgical margins or resection margins. This is where the surgeon's knife meets the patient. Exactly that point is a surgical margin. It's the end of the tissue resected. So it includes surface mucosa, submucosal tissue, deeper connective tissue all around the tumor. So the types of surgical margins are, we have histological margins. As oral pathologists, we screen the margins of the resection specimen for any evidence of tumor cells. That is the histological margin. Then we have mucosal, submucosal, skeletal, and bone margins, which has been proposed by the Royal College of Pathologists. So, if we want to see the mucosal and the deep margins, if we see this picture, this is a tumor mass. If we see the distance from the tumor mass to the margin, there's a distance of 5 millimeters, which is adequate. So, a histological distance greater than 5 millimeter is a clear or a negative margin. Now, here you see the margin is almost, the tumor is near the margin. So, this is a positive margin. And close margin is, this is a close margin where the histological distance of 1 to 5 millimeters from the carcinoma to the surgical margin. So this is the clear margin, this is the positive margin, and this is the close margin. Now, sometimes we find molecular margins. The histologically normal margins may harbor genetic changes which we will not be able to see unless we do some IHC or molecular uh, investigations. Now, sampling of tumor margins, it is done in two ways. One is perpendicular. Now, if you see this, this has been taken at right angles to the edge of the specimen. This is the right angle. This perpendicular sectioning has been taken at right angles. It shows relationship between the edge of the tumor, this is the edge, and the margin. This is a surgical margin, the red line, and this is the edge of the tumor. So this shows a relationship between the edge of the tumor and the surgical margin. The second type is shave, or we also call it as tangential. It is taken parallel to the edge of the specimen. You can see this. This box was perpendicular in the previous one. This is parallel to the specimen. Large surface area can be evaluated. This will help us only to tell whether the margin is involved or no. Whereas the previous one, the perpendicular, will tell us the relationship between the edge or between the margin and the edge of the tumor. So this is mainly used for luminate structures. Now, based on the site, we can there are some features which tell us whether the margins can be involved or no. For example, let us see tongue. The margins involved involved margins less common. Why? Because of the anatomy of the tongue is such that when the hemiglossectomy is done, there is adequate tissue for achieving clear margins. I will show you in the next picture. Floor of the mouth and retromolar area show involved margins. That is because, first of all, floor of the mouth, pore axis, there's loose areolar tissue, and the muscle bulk. It helps in uh, infiltration. Then buccal mucosa. The elasticity of buccal mucosa influences involvement of margins. So the involved margin involvement is more. Actually, what I read in the articles is more because of the elasticity of buccal mucosa. Now, if you see this picture tongue, this is a tumor mass. There's a lot of space for marginal clearance, if you can see. So, the anatomy of the tongue is such that the margin involvement will be less. Now, why there is a discrepancy between the margins measured by surgeons and analyzed by pathologists? Once the sections come to us, once a specimen comes to us and we start processing it, we know there's a lot of shrinkage, and lot of shrinkage will be seen in margins which do not have support of bone. And when the tissues are removed, there is a decrease in dimension, because when the surgery is done, the tissues are under tension, and when the tissue is given to us, there is surgical release, so the dimensions will vary. So that is why we usually find the discrepancy, the margins measured by surgeons and analyzed by pathologists. Why there is recurrence? Even after we have given a report as clear margins, why is there a recurrence? Residual cancer cells, they are undetected by histopathology, routine histopathology. That is one of the problem. Next is a field of genetically altered cells may be present which are not noticed and which have not been included in the margin, which we will not be able to do unless we identify by IHC. Then inking. Inking, we know the ink what we use, it should be bright, and the main requisition for or a requirement of a dye is it should not smudge into the surrounding tissue. We get false positive results or mix with other colors. It should be easily applicable, and it should stick to both fresh and formalin fixed tissues. Fat and parenchyma should not influence the color of the dye. That is one of the other requisites. And there should be no color change during histopathology. So the dyes we use is India ink is one of the dye. Sometimes the surgeons clip the margins and send it to us or place a suture. Sometimes we do use dyes also. India ink, it is a protein based dye which securely fixes the tissue by cross linking. But when multiple margins have to be assessed, India ink is not going to help. So acrylic colors are used. These acrylic colors are used available in many colors. They're affordable, they're non-toxic, non-inflammable, and stable. And one more thing about these acrylic colors is not all acrylic colors will withstand tissue processing. Some acrylic colors definitely withstand tissue processing. And what the importance of these acrylic dyes is they do not alter the nuclear and the cytoplasmic details or the morphological details, and they do not interfere with uh, IHC. So acrylic dyes are better than India ink. That's what the studies say. And they have used different dyes for different margins. Then how do we apply the dyes? We take a cotton tipped or wooden picks, and they should be constantly filled and blotting of the applicator before applying the dye. And a fixer or color enhancer is very important when we use a dye, which is usually acetic acid. So the common procedure, the dyes are very effective when we use it on unfixed tissue before sectioning. Fresh, fresh tissues should be patted dry. It's better to do dyeing on a fresh tissue. The dye should be applied in air dry. Fixer should be applied after the dye is dry. And we should be very careful that we don't cut the specimen when the ink is wet, because the ink will be carried by the knife onto the cut surface. So the color coding I was talking to you about, the acrylic colors that I used, usually they say red is for anterior surface, yellow for posterior, blue for superior, and green for inferior. Now, after inking, after we have got the specimen and we have inked the margins and we have been very careful doing so, still we get some uh, false positive margins or false negative margins and all. Now, if you see in the picture, this is a true positive margin. This is the ink. This is the inked margin. The tumor extends to the true margin, to the true surgical resection margin. The microscopic section also shows the tumor extending into a correctly identified resected margin. This is a true positive margin. Now, if you see here, the tumor extending to a tissue edge but will not recognize it as a margin, because if you see this, the ink has not been applied. So this is a false negative margin where the ink has not been applied at all here. Here, if we see, the ink has seeped into the tissue due to, we have not been able to identify the anatomy properly or misinterpreted the anatomy, or there is leakage of the dye. So it has seeped into the crevices, or it has seeped into the tissue, and or it has been speared because of the gloves we have used or the scalpel blade. As I told you earlier, on wet tissue we should never try to section because it will carry this uh, dye. So that was a false positive margin. Now mislabeled true margin is, this red dye has been used, that means this is a wrong color dye. The previous pictures I showed you the black dye. This is a wrong color dye which has been used because of the orientation of the specimen has not been right. So this is because of misinterpretation of the specimen orientation, and this has been reported as this has been shown as posterior superior margin. So this is a mislabeled true margin. Then tissue cassettes, we all know. Now we have in the margins, we have, if it's a small biopsy specimen or a large specimen, we have sectioned, we have done the cutting of the and specimen, and all the steps are over in the glossing. Now we are going to place the tissues in the tissue cassettes. These are small perforated, they are plastic containers are made of steel, but we usually prefer plastic containers now, and they protect the tissues from damage, and they are made up of high density polymer or acetyl polymer. Now they are of three types. One is the biopsy cassette, which made up of small perforations, mega cassettes for big tissues, and this is a multi-well cassette where multiple chambers are required for holding the specimen. Now, why do we need frozen sections? Frozen sections is for the rapid diagnosis of intraoperative management. When the patient is still in the operation theater, the surgeon wants to know the involvement of the margins, or the lymph node involvement. So and also extent of the lesion and assessment of surgical margins. But as pathologists, we can report our report is limited to benign or malignant. So frozen sections is the on the spot diagnosis. If at all already it's a confirmed malignancy, we need to tell if the resected margin is clear of residual cancer, or residual cancer is still present. If there is cancer present at the margins, we need to clarify that. So, for frozen sections, the tissue should be received fresh. For example, we receive a fresh lymph node. We need to make cut smears of lymph nodes which are suspicious, especially for lymphoma, if all the investigations are pointing towards lymphoma. To freeze fixed tissues, if they are already fixed in to freeze the fixed tissues, it is better to use formalin as a fixative rather than alcohol, because what will happen is alcohol fixatives are very hard to freeze, and we should avoid freezing with heavy metal salts and even Zenker's solution, as they cause lot of shrinkage. And tissue size, when we freeze it, it should not be more than uh, 3 to 5 millimeters, because such small specimens will show less ice crystal artifacts. Crystallization will not be seen, and they have shorter freezing time. And what we should avoid is bone, cartilage, fat, and if the patients are known to being diagnosed with tuberculosis, then we should need to avoid all these tissues. So this was about, in general, grossing. Start right from receiving the specimen to processing the specimen by putting in tissue cassettes and so on, and also frozen sections. Now the grossing based on tissue. For example, very rare scenario, we get a blood vessel. Actually, why is the blood vessel removed? It is removed surgically if there's any aneurysm, hemangiomas, or vascular malformations, or varicose that cause bleeding. So if we at all we get, in our oral pathology scenario, rarely we get grossing. What do we do? First, we check for dilatation, obliteration, any thrombi, any hemorrhage. Then we measure the length, diameter, and the wall thickness of the blood vessel. The outer surface, we check for any abnormalities, any nodular presentation, and if it is the surface is having any disfiguring. Then always the blood vessel should not be serially sectioned immediately. It should be submitted in toto for processing, right from fixation. The blood vessel should be sectioned in cross sections only at the time of embedding. And when we embed the tissue, the cut end of the vessel should be facing down. Now, if we are getting a nerve, why do we get a nerve biopsy? This is also very rare. If it is neuropathy, if the patient is having constant pain, paresthesia, tingling sensation, or if there are any tumors and chronic pain or entrapment of the nerve. Now, for example, in adenoid cystic carcinoma and all, there is perineural invasion. Such scenarios, we may get nerve. So the specimen should be at least 2 to 3 centimeters in length. If it is fixed in formalin, if the tissue is sent in formalin, we usually use green cassettes, and the fresh, that is, and processing as for paraffin nerve section. But if fresh nerve is sent, we can take 2 to 3 cross sections or 1 or 2 longitudinal sections. And the nerve should never be pinned, it will cause mutilation of the nerve. And it should always be transported on a non-absorbent material, and it should not have any contact with fluid. Now, a nerve biopsy can be sent to us in formalin. Then we follow the routine fixation procedure. If it is sent fresh, what we can do is, this is a nerve that is being excised. Now we have got a 2 to 3 centimeter length nerve. We have put it on an index cardboard or index board. We hold one end of the nerve with a forceps, and the other end, when we hold it, it will get attached to this board. Then what we do is, in this you can see the board is cut all around, and after that we can slice it into two. You can see this picture here. So when we slice it into two, one we can put it in formalin and one we can put it in glutaraldehyde for electron microscope. If so, there are three scenarios. One we can receive in formalin, so it will be fixed. We follow the routine processing. If it is unfixed and electron microscopy study is required, we use this procedure. Sometimes for neuromuscular study, we have to send it fresh. So fresh nerve received in saline, we stretch it to the normal length, that is the previous picture showed, holding one end of the forceps on the index card, and then it will get adhered to the index card. Then you cut it all around and divide it into two portions. One will be in formalin and one will be in glutaraldehyde. But if the specimen has to be sent for neuromuscular lab, the specimen should be wrapped in gauze, moistened with normal saline, placed in a watertight specimen jar, and transported in wet ice. This is the protocol if neuromuscular study is required. Even for muscle, we usually follow the same protocol. So this is the nerve. This is to show you that 2 to 3 centimeters of nerve is required, and these are the wraps which they use. Now we have seen blood vessel and nerve. Next is salivary gland. When we get a salivary gland, first thing, the whole salivary gland, rare occasions we may get, we have to weigh and measure the gland. Then we need to examine the external surface of the gland, like whether it is well demarcated, encapsulated, or poorly demarcated, and look for any safety pins or tags or sutures if the surgeon has placed. Then we orient the specimen and we ink the margins, and we have to section the whole gland at 2 to 3 millimeter intervals. Salivary gland tumors, cut section give us lot of information. They can be cystic contents, they can be myxoid like material, gel like contents, and they can be hard tissue, they can be tissue resembling bone, cartilage, and it can be multinodular or multicystic. So, all these features give us a clue to the diagnosis even from the cut section. The parotid gland, especially, we have to check for the intraparotid lymph nodes. And the parotid duct, also, if we are able to find, it gives us a clue the superficial and the deep relationship of the mass to the facial nerve. That also helps. So, if we are given the whole gland or if it's a large tumor, we need to section one section for every 1 centimeter of the tumor, which includes the tumor center and the periphery. And if it is little smaller, we need to give the entire tumor at least in 5 sections. That will suffice for the diagnosis. And we need to save some tissue for special stains, as we require a lot of special stains in salivary gland tumors. Next is lymph nodes. So, if the tumor cells are metastasizing through lymphatics, sentinel node is the first to be involved. Now, how do they identify the sentinel node? Is by lymphoscintigraphy. So, what do they do is they inject a radioactive dye near the tumor, And if any of the lymph nodes picks it up, they they inject a radioactive dye near the tumor and they see it with a camera. If any of the lymph node picks it up, they send that lymph node for histopathological examination. Now, if you can see here, this is a lymph node with a radioactive dye, supposedly a sentinel lymph node. Sections have been made like bread loafing. If there are macromets, that is more than 2 millimeters, at least one section will show. But if there are micromets, that is less than 2 millimeters, we need to sample the whole lymph node and take multiple sections to actually recognize the micromets. So this is a lymph node with a radioactive dye, where bread loafing has been done and sent for processing. You can see the metastatic deposit in at least one section, which is not so in case of micromets. Now, when do we get a single lymph node? I'm talking about single lymph node because I have not gone into radical neck dissection. So we can get a single lymph node, say for example, if it's lymphoma, Hodgkin's or non-Hodgkin's, sarcoidosis, tuberculosis, or a metastatic lymph node. So what do we need to do first is measure the lymph node in all the dimensions. So, based on the size, we decide what to do. If it's a very small lymph node, less than zero point 0.5 centimeter, we will take the entire node for processing. If it is less than 1 centimeter, we can bisect the lymph node. If it is greater than 1 centimeter, what we can do is a bread loaf, cut 2 millimeter thick slices perpendicular to long axis of the node. If the sizes of the lymph node is more than 2 centimeter, again you section like bread loaf. Then cut section, or first the surface of the lymph node, we can see consistency, nodular, cut section, we can see consistency, nodularity, hemorrhage, necrosis, all these on cut surface. And if it is totally, a metastatic lymph node and a lot of, if it is a metastatic lymph node, sometimes the surface may be totally effaced. If node is fresh, what we can do is make touch imprints. So, if we after we make the touch imprint, we need to fix it in 95% alcohol for HND stain, air dry for GIMS or right stain, and snap freeze so that 1/4 of the node at least we can keep it for molecular studies. Now, what is a snap freeze? The tissue, we store it under minus 70 degrees centigrade with liquid nitrogen. What happens then is the DNA, RNA structure, and proteins are well preserved, so we can use it for molecular studies. The end of the node is always used for microbiology culture. If the node is very large, we can use one section for further investigation. If we are suspecting lymphoma, you can use fresh tissue or already the processed tissue for IHC. Now, this is a picture showing a lymph node. Here, if you see the picture, the fat has been removed and it has been cut. And here, this is the bread loafing of the lymph node. Now, the tongue. When we get a tongue specimen, usually it is hemiglossectomy. We orient the specimen, identify the suture, and if suture is labeled anterior, posterior, superior, right, and left, that means they are talking about the dorsal surface of the tongue. If the sutures are labeled anterior, posterior, superior, and inferior, then it is a lateral surface. And next, so anterior, posterior, and right and left will always, it means dorsal mucosa. Anterior, posterior, superior, and inferior will mean lateral surface. Then we need to photograph the specimen, intact specimen, take the measurements anteroposterior, mediolateral, superior, inferior. And also we need to measure the distance from the mucosa to the margin. Now, if you see here, the anterior and posterior have been sectioned, and then again like a bread loaf, it has been sectioned because these sections are very important to us. Now, these sections at regular 2 to 3 millimeter intervals, the sections have been taken. Here, what happens is some parts of the tongue may show, just minimal dysplasia, or it may show uh, like leukoplakia like areas, or it may show frank carcinoma. So, end to end, the sections have been made. So this is how a tongue specimen is grossed. These have been taken separately, and again, like a bread loaf, they have been sectioned because anterior and posterior are very important to see the extent. Now, mandibulectomies. So we have two types. One is marginal, which involves only gingival mucosa, teeth, and superficial portion of the mandible. Whereas segmental is right from the whole thickness of the mandible, that is mucosa, teeth, bone, and the muscle. Everything has been removed. This is segmental, and this is just a marginal mandible. So for grossing of mandible, we need to orient the specimen and note laterality. That means which side of the body is this lesion seen, and take measurements anteroposteriorly, mediolaterally, superior, inferior. Then we need to measure the length of the mandible along the alveolar border. That is the next step. Then we need to see the size, color, appearance, if the growth is proliferative, papillary, or verrucous. And then we need to see the distance of the mucosal cut margin from the tumor and photograph the fresh specimen in all planes. For small specimens, we need to fix in formalin overnight. Large specimens, we need to section it before fixation. Now, if you see this picture, this is blue line is a bone, this is white line is a mucosal, and this is the soft tissue. So, whenever we send the specimen for the margins, we need to send the uninvolved tissue, the mucosal tissue, soft tissue margins, the bone, and the submucosal or the deep mucosal tissue. Now, if you see this specimen, it has been sectioned from the surface to the inferior border. Now, why this is done is at irregular intervals to see if the inferior border of the mandible is involved, because the treatment will vary. They may have to give radiotherapy. So, if it is involving right up to the inferior surface of the mandible, it's involving the inferior surface of the mandible, we need to see the margin, whether this inferior border is involved, and the treatment may vary. But if it is ending somewhere in the medullary cavity, the treatment will be different. So that's the reason this specimen has been cut right from the surface to the inferior border of the mandible. So ink margins, as I told you, mucosal margins, soft tissue margins, bone margin taken end phase. End phase means forward position, forward part need not be inked. Bone margin taken radially, that means from the center to the margin, we need to ink the cut surface. Maxilla, the grossing is the same as we do it for a mandible, but sometimes what happens for a maxilla is the orientation, you may not be able to identify the margins. So, if we see teeth, that indicates floor of the maxillary sinus. If we see nasal guana, it indicates medial aspect, and skin from the cheek, lateral aspect. So, floor of the sinus, a tumor from floor of the sinus will extend laterally into the palate and also inferiorly. If the tumor is placed medially towards the midline, it will extend to the nasal cavity. If it is to the lateral wall, it will go off to the skin and the soft tissue of the cheek. And if it is superior roof of the sinus, it will go to the orbital region. This already you must have, we all know the CA of the maxillary sinus. So this was a brief description of grossing and all the specimens individually. How do we gross the specimen? I have not gone into bone decalcification because the time will not be enough to do bone decalcification and radical neck dissection. So this, the some gross specimens which I would like to share with you. This is a periapical granuloma, and this was a cyst. The cut section showed a cystic cavity, but we need to correlate this with the radiograph and the vitality of the tooth, which is very important. This was, you can clearly see, attached to the neck of the tooth or the cemento-enamel junction. So a dentigerous cyst. This, if you observe, there are keratin flakes here. So when there are keratin flakes, it is not that we should not send it for processing. We should send it for processing to confirm it is keratin. So this is a case we got recently. These are the keratin flakes. Then this was the radiograph. As I told you how radiograph is important. There was a destruction of the cortical plate, and you can see the septal bone, and here you can see the cystic cavity with a cystic lining. This was a case of ameloblastoma. It was a unicystic. This was again a unicystic mural type ameloblastoma. Radiograph was taken. You can see the radiolucency here. And this was a beautiful video created by Dr. Abhishek Badrana, but unfortunately not able to play the video. The cortical plates were intact. So he made a window in the cortical plate and scooped out all the cystic contents. Very beautifully done. This was a mucocele on the lip. You can see the mucocele with the minor salivary glands, if you can appreciate. And this was a cut surface. There were two cases. It shows that jelly like substance here on the cut surface. This was mucocele, but this was again looking like a mucocele. You can see the cut surface showed jelly like material, but this was on the palate. And this, when we saw the slide, it was a classic case of low grade MEC. So, just by this picture, we need to think of mucocele and MEC, but based on the site. Lower lip and all, 90% of the cases, it will be mucocele. This was a papilloma. If you can appreciate in the gross itself, the finger-like projections. This was a case of varicose hyperplasia. Now, if you see the specimen like this, you will not be able to appreciate the finger-like projections. But the cut section shows beautiful finger-like projections. So this was a case of varicose hyperplasia, which was not evident when the specimen was not cut. This, of course, is a case of fibroma. The cut section, if you can appreciate, it shows a yellowish hue. So we thought it could be a lipoma also, but the adipose tissue was a normal component there, and we gave it as a fibroma. This is not our case actually. This is a lipoma. I just wanted to show you lipoma floats. Now this was a beautiful case of myxolipoma. You can see serial sections have been taken of this specimen. This was a whole specimen. It was cut and serial sections were taken. Now when we saw this sections, initially it showed only adipose. We thought of fibrolipoma. But when we saw the deeper sections, it showed myxoid component. So we gave it as myxolipoma. So it is important that we take as many sections as possible, deeper sections. This deeper sections gave us a clue about myxoid, about the myxoid component. Now, if you see this, there are a lot of yellowish nodules here. When we see such yellowish nodules, we need to send it for processing, not ignore it, because this may be cholesterol, it can be, ghost cells. So we need to send it for processing, especially this, or it can be just fat. This was a matted lymph node, which we see in tuberculosis, sometimes in neoplasms also. Very commonly in granulomatous infections, we see matted lymph nodes. Now, this is why we have put up the slide is this is a H&E stain slide. You can see this finger-like projections. This is not under the microscope. Just seeing the slide, we could make out these finger-like projections. So sometimes seeing this itself, it will give you a clue. And also, the gross specimen definitely will show us the finger-like projections. Thank you. Thank you, Dr. Mandana, for giving me this opportunity. I would like to thank Dr. Priya, Dr. Ashwini, Dr. Abhishek, Dr. Jyoti, and Dr. Gopika. And all this grossing, what I showed you, have been done by Dr. Priya and Dr. Abhishek. I wanted to show the video, but somehow I'm not able to play that video here. Thank you so much, Dr. Mandana, for giving me this platform to present something on grossing basics to something what I know. Thank you so much.
Oh, sorry. Okay, here I am. So, could not help but really smile at those. What wonderful specimens and what an amazing lecture. Thank you so much.
I hope it is useful. Unfortunately, we don't have many postgraduates. Hope it was useful. If they were there, maybe the basics would have really helped them.
Ma'am, most of them watch it afterwards. It
Okay.
stays on the channel, they watch it afterwards, don't worry. Ma'am, I just have one question. Have you turned the settings of the camera with blur your background? Maybe that's why it's looking so blurry.
All now, just now, it's looking blurred.
No, it was looking blurred from before. That's why I actually brought the slide over your image so that it will not be
Okay.
distracting.
Okay. Okay.
From that settings wheel, if you can just go and click on the camera. Oh, sorry, you have to click on the virtual background and remove the blur, background blurring,
Remove the blur. Remove the blur.
if it is possible. Maybe that will help.
ఇక్కడ blur remove చేయి. లేదు వాళ్ళకి blur కాదు. I don't think I can do it.
Okay, no worries. It's all right, ma'am. No worries. You can see us, right? So
Yeah,
I
yeah.
can bring the questions here and you can see. And so we have one we have is actually a tip from Professor Hiller. He says a tip for restoring specimens post fixation, color before photography. Rinse the specimen in 70 to 90% alcohol or methanol. This helps with the color.
Thank you so much, sir.
And then he is asking, can you suggest if the specimen has to be embedded on edge or cut surface down?
Cut surface down most of the time. I showed the pictures of core biopsy and all. It's always a cut section down. Even a blood vessel, it's a cut section.
Thank you. And then he says, I love your exposure on the core biopsy cutting and embedding. Exactly. Okay. And by the way, everyone, please put in your questions and or comments. Okay. And Professor Hiller is also asking, do you have a tip for the fixation of a margin dye on fresh tissue prior to frozen sectioning?
Margin dye. We dye the specimen, a fresh specimen itself. Uh, Other than ink dye and India ink and acrylic colors, does sir mean that?
I don't know. For the fixation of him, no, I don't really know what he means. Let's see, maybe he will put a comment again. Okay, Dr. Deshpande says, thank you very much, ma'am. It was an amazing lecture. It truly was. And Dr. Archana also says, excellent presentation, ma'am. Thank you. Okay, I would like to know more about RFID active or passive.
RFID active, it helps us to scan the specimen at every checkpoint. What I mean is, at the level of receiving the specimen, accessing the specimen, processing, then embedding, grossing. Embedding, staining, sectioning, staining, and lastly, uh, till it reaches a pathologist's room. So that is active. But passive, it uses this electromagnetic energy. Active uses battery. And the passive one, it helps us to securely and efficiently manage the specimen. So I feel active is better. I have also put in the slide the difference between active and passive. Though I did not speak about it, you all can always go through the presentation and see the difference between active and passive RFIDs.
True. And Dr. Selvi is with us. Very good presentation, Dr. Sharda, ma'am. Thank you.
Thank you, Dr. Selvi. Thank you so much.
Okay, then of course, this is something all of us have to say. Those were beautiful gross pictures. This is Dr. Gauri who's saying it. I think everyone is just saying very nice. Dr. Mahadevi also says very nice. Dr. Soundarya says very nice. Dr. Sahana Ashok says awesome presentation. Dr. Rupati says very informative. Thank you, ma'am. Dr. Tara Dwivedi says thank you for such an insightful lecture, ma'am. Really appreciate the entire OP360 for conducting such sessions. Thank you so much. Although really our contribution is just it is people, great speakers and great educators like ma'am who make oral pathology 360 possible. So yes, we have to thank them. Oh, we have some other questions. Okay. Thank you. Professor Hilla also says, thank you for the well illustrated, comprehensive lecture. All postgrads should watch this lecture early in their courses. That is very true. Dr. Bowen also says, excellent presentation. And Dr. Anila also has said, very good cross specimens. I really have to say, those were fantastic. I couldn't help but smile. And also, after a long time, I literally missed being able to be involved with grossing and with tissues again. Okay, he has got this. I meant to get clarification on how to best fix the ink on a margin of a fresh tissue specimen prior to frozen sectioning.
I'm not sure about this. Usually we ink a fresh specimen, but how to fix the ink? We use a fixer. That is what I've understood from a question. After we apply the ink, we use a fixer, 3% acetic acid, so that the ink will fix on the margin. That is what I have understood from Sir's question. But if there's
I think
anything else,
that's correct. Yes, I think that's exactly what he wanted to know. So basically, you use 3% acetic acid.
we fix the ink after applying the ink. We fix it with the. That's called a fixer actually.
So, yes, correct. Okay. Again, we have more thank yous and
But
more.
I'm not sure if it is for a frozen section. That I have to clarify. I'm not very sure.
Okay, right. Okay, everyone. So we have. I don't really see many more questions. Let's move to. Oops, sorry, wrong one. Okay, everyone, start typing. This is what you got to type for getting included in the giveaway. You have to type hashtag IODCPC25 in the comments, and well, just type it, and after some time we will run the giveaway. Okay. Uh, and in case you already have registered and you win, you can always give it away to someone else. Okay, Dr. Selvi has asked something. Let's see. Okay, what is your opinion on use of stereo microscope for surface viewing of specimen?
You mean tooth specimens, bone?
I think she means any specimen probably because surface. So, Selvi, can you add another comment as a follow up so we know exactly what you
We
mean?
used to usually use for teeth specimens
Yes, for hard
to
tissue.
for impregnation of the dye and all that, which usually conservative people, try to see. So we used to see tooth specimens or the cut section of a tooth specimen.
True. Okay, let's see if she will type anything. In the meanwhile, yes, this is what I was actually searching for. Ma'am, I know a certificate seems very redundant when I give it to you with all the things you must have got, but this is just a token of our appreciation and a memory of this day when you were on Oral Pathology 360. Thank you
Thank you
so
so much,
much.
Dr. Mandana.
Thank you, ma'am. And we do hope you will come back with more lectures, of course.
Thank you.
Dr. Mahadevi is saying she would like to reach out to you if she has any doubts.
Sure, sure. Definitely.
Yes.
Now I'm just working as a practicing oral pathologist. I am not attached to any college, so I'm free. She's free to, call me or talk to me whenever she wants.
True. It is good that you are a practicing oral pathologist. That's exactly the kind of example we need for the youngsters.
But I miss college life. 35 years was a long time for me to work in college.
That is true.
And
That
that
will
was
never go away.
non-stop, continuously I worked. So I
Yes,
miss that life. But age also matters. You cannot work after a certain age.
that is
We need to
true.
give chance to youngsters. So that's
Yes, that also. There are the many things that happen in life, and one just sort of uses and, do the best with it as it happens.
yeah.
Right. So, mm, sorry. I got to go here. Okay. So, do you think that has been enough time and should we run the giveaway? Has everybody finished typing the IODCPC25? I can see quite a few have. Okay, in the meanwhile, let me tell those who are here. I can see quite a few of our members have attended the uh, lecture. So, if you want your certificate, you need to go to the posts that are there, our posts on YouTube, and you will find a members only post that will give you the link to the certificate. And if you have activated notifications for our channel, you will even get an email, something that even I didn't know. Dr. Bhuvan told me, which was interesting. Yes, we have a lot of people. Okay, I think it's time. Let's run this. We are going to start now. All the best, folks. Dr. Sahana, wonderful. Congratulations. You will get your registration. But do you remember you have to send me your email before I can give you your registration? And I need a, sorry. Oh dear. Okay, no worries. I will see it afterwards. So, congratulations. And Dr. Sahana will be joining us for the conference. For those who didn't get it, again, do not despair. Well, you can still register, and also you can wait, and we will have one more round of giveaways in April. So you can always try then. Yes. And oh, Dr. Madhavi is telling me, yes, I will call up Madhavi and talk to you about that. Thank you so much. I know that has been troubling you for quite some time. Believe me, it's been troubling me too. Okay, so we have got our winner. And with that, we should go on. And I did tell you all that I need to share something with you. So just stay on for another minute. No, Dr. Sahana, do not write your email here. Can you message it to me if you have my number? Otherwise, you can always email me with mandana at oralpathology360.com or info at oralpathology360.com. I would not like you to share your email on YouTube. Okay, right. Okay, let's do this part. Yes. So we have two things to share with you before we go away. I had told you one is we have the news that last year's book of abstracts is ready, and we will. I mean, the book is now almost ready. Which it just needs to be published, and we hope to release it during the conference this year. That is one. The next thing is we have instituted an award, which will be for an institution that promotes learning and uh, excellence. So this is going to be judged by a combination of factors, starting with how many people are representing that institution in the conference. So how many people are participating, but it's not just the numbers, it is also the quality of participation. So after you have the numbers, you also need to actually be attending the conference, and also you need to be engaged in the discussion. So let me tell you who's leading right now. We have Goa Dental College and Maulana Azad Institute of Dental Sciences, each with 8 participants in the third place. And then we have Chetinath Dental College and Research Institute and GDCH Chhatrapati Sambhajinagar, both at 10 participants, so in the second place. And on the top right now is Vishnu Dental College with 11 participants. So this is where the count is. It is still very much open. You can take part. You can also keep on talking and interacting about the conference. We will be tracking all of that. Use the hashtag IODCPC25, and let's see who is the institution who will win excellence in learning and leading. Let's see. It's open. Okay. With that, and I can, yes, Dr. Deshpande, abstract submission, actually, we had given an extension. It is the hard close, the final close is this evening. I don't know if you can make it till sometime late this night. Okay, right. So, ma'am, thank you so much again for being with us.
Thank you, Dr. Mandana, for giving me this opportunity. Thank you so much.
Thank you. It was lovely having you here. We will wait for you to come back soon.
Sure.
Okay. Okay, everybody. See you next time.
Bye.
Stay connected. See what we are doing. Follow us on all our channels. And then you will know what we are up to at Oral Pathology 360. Bye.